So compulsions that can be also mental that people cannot observe. Sometimes compulsions are simply distraction mechanisms. So if I'm here worried about, is somebody going to break in my house, I might find that if I count ceiling tiles, which it's hard to count them because there aren't many, but you can count ceiling tiles or count the number of people in the room repeatedly, and all that does is simply distract you from the worry. It works to reduce the distress, to reduce anxiety at the time. Typically, things that work the same as compulsions or thought of in the literature as compulsions, avoidance is typically a compulsion. So instead of touching the mouse and then having to leave the room and go and wash my hands, I might decide not to touch it. I might use a paper or use gloves or use it with my elbow. So you see a lot of avoidance behaviors that typically serve the same function as a compulsion. Some of the things that we know about causes or things that are related to obsessive compulsive disorder. There's certainly some brain functions that are different in people with obsessive compulsive. Increased activity in the frontal cortex, which is basically overthinking, overprocessing, overthinking of many things. Basal ganglia, there's an orbitofrontal basal ganglia loop that seems to get stuck in many people with OCD who have very repetitive behavior. So they might put a glass down and they keep doing it several times over and over. The brain, on some PET scans and images, gets stuck in a particular loop. We know there are genetic factors involved, and obviously serotonin involved in just about anything that has to do with psychology. Cognitive behavioral factors. There's some question that some of the OCD symptoms can be a little bit of conditioning based. The most important mechanism, psychological mechanism, is this. You have obsessions, which cause fear and anxiety. Somebody does a compulsion, reduces that fear, makes them feel bad, and that creates that loop of negative reinforcement. Over time, the compulsions increase in strength and frequency, and the anxiety actually over time increases. Compulsions are similar to something that happens in pain medication. People who are chronically addicted to pain medication. Works very well immediately, but over time it makes the tolerance to pain less and the experience of pain more. So over time you'll see anxiety increase and the compulsions get stronger, but it does work at the moment to reduce the distress, and it works quite well for that. Some cognitive features that are common in people with OCD, inflated responsibility. This is the idea that if I don't check everything, my house might burn down and I might be responsible for other people who might die, or they have much greater likelihood of having that. The idea of controllability, that they can somehow, by doing these compulsions, control negative outcomes. If I just wash my hands enough, or if I clean enough, I'm not going to get sick. Studies have shown that there's actually people who, for example, do cleaning compulsions or avoidance compulsions, don't get sick any less. In fact, many of them get sick much more than people who don't do obsessive compulsive symptoms with that. And the other that are pretty common across many psychological disorders that have to do with anxiety. I'll just briefly mention this. I have a few slides for this, but I won't spend much time on this, just a couple of minutes. There is a subset of OCD onset that is labeled PANDAS, and the term is Pediatric Autoimmune Neuropsychiatric Symptoms Associated with Streptococcus A. Some of the features are very dramatic, quick onset, that's episodic. So you'll see somebody with no history of obsessive compulsive disorder have very dramatic onset within a matter of days. Sometimes parents will describe, my child woke up one morning and barely could speak, couldn't touch anything, was walking around worrying about germs, and just out of the blue. And you see this sawtooth pattern. Symptoms come on, they disappear, they come back on, they disappear. Over time, the course can get worse. You see some things associated with PANDAS that you don't see in typical OCD. Choreiform movements and a regression, almost as if the child has become 4 or 5 years younger. We'll talk about that. A couple of other features in a minute. Typically, obsessive compulsive disorder is chronic. Up to 80% of adults. So if you had OCD as an adult, you had 4 out of 5 of them had an onset as a child. It usually does not remit spontaneously, and over time it actually gets worse, partly because of the negative reinforcement loop that we talked about earlier. The more you use the compulsions, the more reinforced they become, and the more difficult it is to work your way out of them. This considerable impairment, obviously, as you might imagine, there's some functional impairment, not being able to type things, shake hands, checking doorknobs, and getting stuck in the house. The typical things that we think about when we think about compulsions. But there's actually impairment that's much more than that, and that impairment is psychological impairment. It's not what you don't see. It's somebody sitting there in the back of the room thinking about, when the meeting's over, am I going to have to shake hands with people? Right? So instead of focusing on the presentation, they might be worried about something different. And it's that mental impairment, the obsessive thoughts, the focus on the anxiety that is oftentimes more debilitating than the actual function difficulties with OCD. So there are two treatments, and we'll talk about these and what they are. So generally, in pediatric OCD, exposure-based CBT, and we'll talk about that in a minute of what it is. Cognitive behavioral therapy that's based on exposure to whatever the fear stimulus is. It's superior to placebo across studies, attention control conditions, and even, especially in pediatrics, more effective than sertraline. Now, in the United States, there are several, I think 6 SSRI medications that are approved for use for obsessive compulsive disorder. Sertraline is the most commonly used one. It's certainly the most commonly researched one, but you can think of this as a generic SSRI rather than sertraline specific. There's nothing specific about sertraline which works any different than any other SSRI, especially the main ones. Most American obsessive compulsive disorder patients are first treated with SSRI medication. Even though SSRIs, relative to placebo, not everybody responds. They're certainly better than placebo, but not everybody responds to SSRIs. Complete remission with SSRIs is very uncommon. Most people have some improvement in anxiety, some improvement in functionality, but nothing close to remission. And especially for pediatric patients, and especially for pediatric patients that have other issues like autism or spectrum issues, there can be significant side effects and tolerability issues. Quick review, I'm not going to go much over this except for a couple of things. Behavior-based psychotherapy, cognitive behavioral therapy, but particularly the behavior part, has shown to be significantly effective for the treatment of obsessive compulsive disorder in children. Family-based CBT is particularly helpful. Children aren't going to go home after a therapy session and work on the things that need to work on during the week. They simply don't do it. Partly because, as we'll talk about in a minute, treatment for OCD is aversive. It involves intentionally exposing yourself to whatever is your trigger. And children simply aren't going to do that without a lot of encouragement, help, and in many cases contingencies. You can't play your games until you finish your OCD homework, just like you would with school homework. One of the main studies I want to cover very quickly, the POT study, Pediatric OCD Treatment Study, looked at sertraline, CBT, and combination and placebo. And what they found is the combination treatment had the highest efficacy, followed by the CBT group, and which was better than the sertraline-only group and the placebo group. Incidentally, these two conditions were not any different statistically, and these two were not any different. So sertraline in that study, which is a very large multi-site study, and I'm not listing the authors because there are 30 of them on that one. It's a consortium group. So what they're really saying is that CBT along with sertraline is the best treatment, and better than sertraline alone, and certainly better than placebo. This is a graph. We have to put at least one graph in a talk, right? This is right before I joined this lab as a fellow. I did my fellowship where I'm working now. And what this is looking at the format of treatment. How do we apply that treatment? And I'll quickly talk about why this is important. Good cognitive behavioral therapy, good exposure-based therapy is difficult to find. There are many people aren't trained for that. Typically, standard cognitive behavioral therapy does not really work for OCD because of a couple of key ingredients that are missing from that. So there are many people in many parts of the United States who have no access to good CBT. So we say, okay, and we'll look at some other studies that, yes, cognitive behavioral therapy is great, but what if people can't get to it? Intensive cognitive behavioral therapy is basically daily sessions, usually for about 15 sessions or anywhere from 15 to 20 sessions or sometimes more. And what that allows people to do is go to a center or go to a site like ours, for example, where they can come, get 3 weeks of treatment, have sessions every day, and then go back home and apply and keep working, maybe with their local therapist or on their own to follow those things. So the question is, does that work as well as the traditional psychotherapy? You come into a session, you do a session, you go home, you practice the stuff, then you come back the next week. Obviously, practice time between sessions is much, much lower for daily sessions. And what we found is that at post-treatment, 90% of the intensive group and 65% of the weekly group are respondents. So the intensity of treatment actually seemed to help in this case. Having daily sessions led to more improvement after the number of sessions, 15 sessions, whether it was when it was done daily as opposed to 15 sessions spread out over 15 weeks. But that might be expected because of the high intensity. What's important is that at post-treatment, the weekly group caught up. So post-treatment, this difference was non-significant. So after, and I think this was I think 3-month and then a 6-month post-treatment. At the end of, at the follow-up time, everybody was sort of equal. The intensive treatment, who had very high response rate early on, came back a little bit, and the weekly treatment actually improved they got even better after the follow-up, during the follow-up phase, and they were about the same at the end of it. So take-home message, intensive treatment, daily sessions can work very well, just as well as weekly sessions. And it's also particularly important for somebody who is very dysfunctional. For example, a child who simply cannot go to school. What else are they going to do with their time? They might as well come in daily sessions and get better in 3 weeks as opposed to having once-a-week sessions for 15 weeks. It's a number of sessions that are very important, unlike, for example, depression or other psychological disorders. POTS to follow this something similar to that up with an age group that involved even younger kids and followed up on that. And what they found out is that 30% decrease in symptoms with the combined treatment versus, here's the data. The meds plus CBT, again, the combined treatment, almost a 70% response rate versus, this is simply a sham treatment. We just tell them about what CBT is, but don't actually do it, versus medication. This did not look at CBT alone, partly because of funding issues. It had to be looked at along with medication. This is a study that we've completed relatively recently, the last 2 years, so it got published last year. And I'm not going to go over this very detailed data of it because it's available. You can just download a PDF of it. And if anybody needs copies, I have my email. I can send you manuscripts for these things in case you don't have access to these for free. This was an 18-week study, total N of 47. They were randomized to one of 3 conditions. Standard sertraline plus CBT. So standard sertraline is started out with 50 to 100 milligrams, and very quickly, if they needed it, stepwise, go as high as 200 milligrams of sertraline. Solely titrated is the idea that we start at very low doses, 10 or 20 milligrams, which is much lower than would be generally prescribed even for children, and titrated up to the starting standard dosage. And the reason behind this is that sertraline can have some tolerability issues for children, for example, who are on the spectrum. Kids with autism or other types of neuropsychiatric issues can have very high sensitivity to many of these SSRIs, particularly sertraline. So slow titration can help check that response and check and see if there is an activation syndrome or something that's negative effects, adverse events of that. And then third condition was placebo plus CBT. And here are the results. So we looked at Yale-Brown Obsessive Compulsive Severity Scale, which is the gold standard used in almost, I'd say almost, but I can't think of an OCD study in the last 10 years which hasn't used that scale. So we looked at that and also looked at response and remission status. And the overall message is that there was certainly very clear evidence of CBT effectiveness. Standard sertraline plus CBT were slightly more effective than the CBT plus placebo. So cognitive behavioral therapy works. Adding standard sertraline improves that response rate slightly. The sequentially provided, the titrated sertraline had no improvement over placebo, surprisingly. I'm not sure why that is. We have a few theories on that, but that's a little bit of a surprise. So why does sertraline that is titrated up slowly does nothing over placebo? There was no group or time interaction, so over time, the response pattern did not change. Even though the response pattern was different across groups, the overall, there was no interaction with time. So the type of response didn't change as time went on. Another way of saying, for example, that it's not like 3 months later, a group that hadn't responded as well earlier responded later, or vice versa. Why am I doing that? This is another study that we completed, have just completed. We're actually finishing up our last few subjects out of this. We have some preliminary data from this, but it's not published yet, and so I would take this stuff with a grain of salt, but we're fairly confident in some of the data. So decycloserine is an antibiotic medication that is shown to be effective in helping treat other anxiety disorders. And the basic idea is that while in the acute active phase of the drug, the brain is a little bit more susceptible to extinction learning. And extinction learning is what we do in CBT for obsessive-compulsive disorder. Extinction learning is the idea that over time, you learn to extinguish the response that you might get from something. A clear example might be that if you're afraid of, whatever that is, chocolate, which I'll give you back. If you're afraid of chocolate, right? If I show you chocolate right in your face, you'll have a fear response. If I keep repeatedly doing that, over time your fear response will diminish. It's used to treat phobias and many other anxiety disorders, and is also very relevant for OCD. And that's what extinction learning is. Here's your chocolate. Thank you. So it seems to help in extinction learning for reasons that we don't understand. And what we know that for the studies that when we administered, and I don't know why it's losing letters, administer about an hour before therapy and give it about an hour, allow it to be absorbed, it seems to help in improving extinction. Compared to the placebo group for this, who both received CBT right after. So basically, you give somebody decycloserine, you wait an hour, then you give them exposure-based cognitive behavioral therapy. And the decycloserine group had a better response to extinction learning than did the placebo group. In other words, their fear got better faster. General approach to treatment. We do the typical CBT stuff, psychoeducation, some cognitive work, but the important active ingredient in all good OCD treatment is exposure. And exposure is repeated exposure to the fear stimulus. And ERP is the idea that after the exposure, you have the patients prevent their typical response. So if it is getting somebody who's afraid of, who has contamination OCD, exposure would be exposing them to whatever they feel is contaminated. Now, this might not be what we know scientifically to be more or less contaminated. This is simply a fear-based thing. And the reason why I say that is because people have sometimes beliefs that something is more contaminated than another thing. It doesn't matter what the real data is. What that matters is what the patients think. So if they think that for some reason computer mouse is mice or mouses are more contaminated than anything else, well, this would be their fear, regardless of what the evidence is. And I'll mention why that's important in just a second. So what you do is create a hierarchy and do gradual and repeated exposure to what makes them afraid without doing their typical response. So contamination, OCD, typical ERP would be you start with, for example, touching this, or holding pens, or shaking hands, or even putting your hand on the surface here. Once they can do that repeatedly with lots of practice, and at some point it no longer causes anxiety or causes very little anxiety, you move to the higher step. For somebody with contamination, the higher step might be shaking hands. It might be touching doorknobs. Once they've done that and have extinguished their fear of that, you move up to higher things. Maybe it's shaking doorknobs in the bathroom, or shaking or touching the side of the garbage can. Once they've done that, you go up higher and higher. How high up do you go? Well, in our clinics, and both in our clinic and in our treatment studies, we go to what people would normally be expected to do, and then a few steps beyond that. You have to push the treatment quite far, because once they're done with treatment, there's a bit of a slide back towards baseline. What would that look like? Well, for somebody who has contamination OCD, it would be going in the bathroom. Once they've worked through all the other exposures, it's touching doorknobs and toilet seats, and eventually for many of them, it's putting your hand in the toilet water. Now you might be looking at me like, we're crazy, we'd never do that, but many of us have done that at some point for some reason. You drop something in there, you put your hands in there, you say it's gross, it's disgusting, but it doesn't ruin your week and it doesn't ruin your day. Some of you might, I see some smiles, some of you may just do that for fun. The high intensity exposures are important, and this is where I think people who aren't trained in OCD specifically, that's where they stop. They don't do the high intensity exposures because patients are very distressed, which is actually part of the treatment. They're supposed to be distressed so they can habituate with anxiety, and then they have a hard time telling the patients, yes, I know you've just put your hand in the toilet, but you can go wash your hands, get on with your day. Cognitive therapy, where does that fit in? Cognitive therapy in an ERP-based treatment model is simply designed to enhance exposure. So if any of you know cognitive therapy, right, it's fixing distorted cognitions. In this case, the only cognitive therapy that one would do is to change the mindset to improve exposure. In other words, one common fear that people with OCD, particularly kids, have, that my anxiety won't get any better. If I do this, I'll get anxious and it won't get better until I go wash my hands. And what we tell them is that your anxiety will get better. That's a cognitive distortion. Your anxiety at some point will come down. It might be 5 minutes, it might be 10 minutes, it might be 20 minutes, it might be an hour, but it's no longer than an hour. That's the upper limit of your high anxiety. It will come down. So that's a cognitive change. The other cognitive distortion that kids will always tell you is that, or adults too, I won't be able to handle anxiety, right? And what we tell them, look, you handle it every day. You end up touching things that you don't want to just by accident all the time, and you handle it. Somehow you manage to do it. You haven't died yet, you've got through. You'll be able to handle anxiety, we can help you handle your anxiety, and those are two most common cognitive distortions that need to be fixed. Typical cognitive behavior therapy, or cognitive therapy. Go ahead and touch the doorknob because it won't kill you or it won't hurt you. Doesn't work for OCD because it counteracts exposure. Remember, the idea of exposure is to expose to anxiety. When you reassure people, if you shake hands, if you touch doorknobs, you will not get sick. That counteracts the exposure part of it. The idea of exposure is to make somebody anxious, keep them anxious until the anxiety habituates naturally, not through any process. That's the one main difference between CBT for OCD and CBT in general. For kids, particularly, family therapy is very important. This is not the traditional family therapy. Let's teach you how to all to get along and love each other. This is more of how to manage OCD and treat OCD in the family context.
Is what you mentioned as CBT family therapy?
I'm sorry?
Is it what you mentioned as family CBT therapy or something?
It's based in CBT, but the idea basically is teaching parents how to help the kids do exposures and do the therapy and not give in to them, not hand them, And I keep using the contamination example because most obvious, not hand them wipes, or not hand them hand sanitizer when they ask for it. Don't open doors for them. Don't open car doors for them. Help them do it. Push them through it, because that's when you can help them keep doing the exposures so they can habituate anxiety. When the families accommodate the OCD, typically it gets worse, dysfunction gets worse, and years later, the OCD is much worse than it would be if they'd sort of helped not accommodate early on.